Hi, my name is David Sallman from Moffit Cancer Center in Tampa, Florida. We just ended a really nice session on maybe the last frontier to truly derive and get novel therapy, immune therapy for patients that have myeloid malignancies. So I got to co-chair with Marion Subklewe from Germany, Dr. Jae Park from Sloan Kettering, and then my colleague at Moffit Cancer Center, Dr. Andrew Kuykendall. So again, we've had a lot of negative efforts, but a lot of trying at the same time. I think maybe start with you, Marion. You really gave a beautiful talk on just the astronomical number of variables. I think when you don't have therapies at work, there's a lot of great science that happens. So maybe start with, what is your approach? I know, what do you think will be the breakthrough, and then maybe just kind of discuss, some of the challenges that we're going through as we speak.
So I don't think that one sort of approach will solve all the problems. So I think we have to address sort of three areas, which I think are the challenge that we need to overcome. First of all, I think mono-targeting will be challenging, and there is the danger of immune escape. So I think multiple targeting has to be considered, albeit there will be toxicity associated. Then I really think we have to work on T-cell fitness and also consider at what stage of disease we're actually using autologous, or if allogeneic T-cells might be more suitable, because patients are mostly heavily pre-treated and have sort of an already compromised T-cell fitness. And then I really also think we have to be aware, and involving data coming out, that there is an immunosuppressive microenvironment. Probably it depends also on the genetic subtype of the AML, and we have to go for combinatorial strategies, or also think of what kind of conditioning we do prior to adoptive transfer of the CAR T cells.
Jae, maybe I'll turn it to you. Your thoughts on this, and then maybe why do we seem to keep maybe just repeating what's being done in the other diseases, right? I think we've been talking about this for a while, but still predominantly in the U.S. we've been at single antigen, and ex-U.S. single antigen, target cells. Your center is maybe starting to push that boundary. So yeah, thoughts on this, and maybe then kind of moving into sort of your multi-antigen targeted approach that you guys are thinking about.
Yeah, I think I agree. Then I think we learned that AML is also very different than the myeloma and then the lymphoma, and even though they're within the realm of the hematologic malignancies. I don't think with the traditional second generation CAR T cells we're going to be able to get deep enough remission or long enough remission to get to these patients to either get definitive therapy or even as a bridge to transplant. So I do think there's a different or combinatory approach that we do need to kind of get these patients. So whether it be armor CAR T cells or addressing the issue of a tumor microenvironment, T cell fitness kind of all together, or kind of the dual targeting approaches that we can do. And even the dual targeting, I don't know if it's bispecific enough that we might get there. I think there has to kind of more of a potentiating effect of the CAR T cells. So we have to ensure these T cells that proliferate. A lot of times when they do get there, they just don't have enough stimulation to do it. So I think some of the things that we're thinking is that what about the the signaling domain? Can we make them less redundant and then less exhausted and then more proliferative to overcome their limitation? And then the cytokines are other ways to do it. So I do think we need to, I think the Marion you mentioned, smart at these approaches. And I think the traditional approach we have seen and realized is just not enough for AML. So I think that's kind of one approach. And I do think the second is that the patient selection, I think as a field that we have to think about this therapy a little bit early. We often get these patients too late, meaning at the end of or at the last resort. And I think this type of CAR T cell therapy, despite its, when it works well, I think it has its own side effects too. It may not be the best setting. So I think getting these patients relatively early when we realize that they are refractory, even MRD positive, as the MRD is becoming much more pronounced and then commonly obtained markers, I think that will be important to get. And the T cells might be better for those patients rather than at the end of the fourth line of a therapy.
So along that, I think actually one of the most important publications in CAR T is your New England Journal article in ALL, where you really saw in patients with the less than 5% blast, that's the patients that were essentially cured. So you kind of alluded to a little bit, is that it? Do we need to really go after MRD? Is this an effector to target issue? But yeah, kind of curious your thoughts. I think we're finally starting that to at least open cohorts once we've cleared, but it's been a challenge. But thoughts on MRD
Absolutely.
targeting?
So I think in this workshop alone, I think solid tumors and then all this disease, myeloma, lymphoma, and then leukemia, I think we've consistently heard that high tumor burden is one of the worst prognostic markers. Why that is, I think we do need to do a little bit better job of whether the tumor-driven or the T-cell-driven, we don't exactly know, but I think that's important. I think the toxicity will be better, and then the efficacy will be better for these patients too. So I do think that the first we have to start. I don't think in AML, I don't know necessarily we have to wait until they're morphologic disease. I think we already know these patients who have gotten a second induction therapy, if they have a 3% leukemic cells, like they are destined to relapse. The challenges are that should we just get this patient to transplant directly with some active disease, knowing that they have a high risk of relapse, or can we try to get them to MRD negative and then get to transplant, or kind of observe those patients? Ideally, the second, I think in order to get there, we need to have a little bit of an efficacy signal or the comfort level that can get these patients. But I think in that setting, the post-transplant relapse, sometimes it's a good setting to test that hypothesis when they relapse after transplant and they have a low-level MRD to get these patients to CAR T-cell therapy. But I do think we will learn a lot more. The patients will do better. I think we'll get better result there.
So Marion, you've done a ton of work on T-cell fitness, and maybe you could just highlight a little bit on HMA venetoclax. Obviously this is in the water now. Maybe it's going to be our frontline therapy for all patients over the age of 60, independent of fitness. So thinking about it, how do you think about utilizing HMA-Ven, the impact on T cells, and could we think about HMA-Ven with consolidation CAR-T in frontline?
Right. So we've started preclinically. Ven-Aza and the impact on sort of PBMCs and particularly on T cells, and at least in preclinical setting we saw no negative impact except sort of B cell depletion, which might be beneficial. And we also studied immune monitoring from patients who are actually receiving therapy compared it to healthy donor controlled T cells. There was no impact on proliferation, cytotoxicity, and it seems to be fair to combine or sequentially to do it in context of adaptive T-cell transfer. And also when we did it in conjunction in vitro and also in the mouse model, it worked really well and had an additive impact. And I also want to highlight there was work by Sarah Gill published in Nature Medicine where they showed that cytokines of the T-cells had a negative impact on CAR T-cell mediated cytotoxicity, mainly GM-CSF, sort of conveyed resistance. And it was also shown that it leads to upregulation of BCL2, and venetoclax can sort of overcome this. So there's even a rationale in that context. So I would really like to see clinical trials where we combine bispecifics CAR T cells in conjunction with Ven-Aza.
Yeah, and maybe especially when patients can still be sensitive. I think the challenge when they're already refractory and then we're using it, optimizing bridging therapy is an important concept.
Right, and I think really, and picking up what Jae already said, we need to move into earlier treatment lines. So I think with genetics and also with MRD markers, we really can identify high-risk patients, and I think it's justified to move those at least after dose finding or something to integrate these in clinical trials.
Now shifting gears a little bit, I think we have our very first MPN colleague at the iwCAR-T. So this is an exciting forefront. So I think Andrew, maybe just give a little bit of a background. How are we going to have novel therapy? Maybe talk about CALR, and we could go from there.
Yeah, it's like a kind of more of like a field of dreams situation.
Yes.
If you build it, they will come type thing. So I think it's interesting to come and kind of obviously learned a lot from the CAR-T development in the lymphoid space, and certainly in the myeloid space been quite challenging. And I think we've wanted to kind of get involved there, but I think the diseases are very different, right? You guys are dealing with very acute diseases and high risk diseases, and I think in MPNs we have more indolent disease, but we have a good target, right? And so I think that's been what's kind of motivated us to move forward with more immune-based therapies, is that calreticulin and CALR sits on it's a mutated protein that sits on the outside of the cell. It's only in the malignant cells, and so represents something that's a rational target. And slowly we've moved in that direction, whether it's monoclonal antibodies, T-cell redirecting antibodies, and now we're talking a little bit about CAR-T. And maybe, especially when Jay's talking about tumor burden and that being, maybe this is more of an opportunity, right? This is a disease state that we can catch earlier forms of the disease, but then we need to match up the toxicity profile with the risk of the disease as well. And so I think it's certainly we have a lot of excitement coming down the road with CALR. I think we have monoclonal antibodies in trials, no data yet, right, that's publicly available. T-cell redirecting antibodies that may be a step beyond that might be able to tackle more high-risk disease. But we also have like a more dysfunctional microenvironment also. So I think, I think that we'll definitely run into some challenges down the road, but I think that as we kind of emerge into this field, it's important for us to start engaging and learning from kind of what's already been learned in other disease states.
So curious, I didn't have enough time to ask in the session. So maybe one concern, there's a lot of bulk of disease in patients, especially when you're having to treat them, speaking to concerns in our space. So how about after transplant? Is there any developments as far as CALR MRD? I think actually one concern I have in MRD, it's that's one thing.
Right.
What are the targets on the MRDs left behind on an individual patient? Completely unknown? Are there molecular subsets that have differential expression? Pretty much completely unknown in that setting. So curious, CALR MRD, is that a thing, or could it be a thing? And would it be maybe relapse is still unfortunately quite high in some of these subsets of patients. Should it be more of a post-allo type strategy? I'm just curious.
Very reasonable, right? I mean, I think we're several years behind the MRD field. I think recently we had New England Journal publication saying that if you're positive for JAK2 30 days after, that's not a good thing, right? I think that's
should have been yours, yeah.
So obviously I think we're not there to MRD yet, but certainly I think that these types of approaches can be kind of combined either before or after transplant, right? Because this is a challenging group to transplant either way, and we don't get. I mean, even with our current therapies, we're not going into transplant, with we have active disease, we're is in the chronic phase of the disease, and I think there's still a debate of how active can that disease be when you go into transplant. Some data would say that you can even go in with up to 10-15% blast or so. That patient's not going to do. Those patients don't do as well, but yeah, I think that targeting these, especially because there's not a really solid healthy stem cell reserve. There's not a lot of normal hematopoietic stem cells in these patients, and so using this as a kind of an induction consolidating with transplant may be an effective way to do it too.
Cool. So I think we had a great myeloid session today. We have ultra rare diseases that we're going after. We have a lot of novel approaches pre, peri, post transplant. But again, hopefully maybe by next year's meeting we'll have some excitement towards some of our first breakthroughs. So thanks for listening.